So they are both a chemical and a physical barrier. They're like a giant scaffolding, like holding the bacteria in like a bowl of jello.
Dr. Jennifer Kerr is a board certified naturopathic doctor practicing in Vancouver, Canada. She also has a virtual practice across Nova Scotia. Her practice focuses on finding a root cause for chronic or recurrent UTI and providing education while integrating the healing power of nature and conventional approaches to care. Thanks again for joining me to share your expertise with our community.
Thanks for having me. I'm excited.
We got a lot of questions about this topic from the community, which we always do when we bring up biofilms. But before we jump into those questions, I'd love it if you can share more about your background and how you came to specialize in UTI.
Yeah, for sure. Just like a unexpected twist, I guess, when I graduated school. But when I was in my second year of naturopathic medical school, we were doing the unit on immunology, and it just clicked for me. I feel like every medical person has something that's like, yep, that's what I want to do with the rest of my life. So we were doing immunology, and I was like, yep, this is it. I love it. And then I shadowed this woman who was doing complex chronic infections like Lyme, mold, MCAS,
Hmm.
resistant infections, and fell in love with her. She was so incredible. And I thought, okay, this is what I want to do for sure. And then after I graduated, I was recommended by a mentor of mine to go work for Dr. Akehurst, who
Hmm.
has a mostly chronic UTI practice as well. And she was on leave, so I took over a lot of her patients and really just loved treating those patients. It's extremely satisfying because you can resolve infections that have been going on for years, and then people eventually forget about their symptoms. And I'm like, oh my God, it's so cool. Um, and then when I was treating those people, I kept running into like road bumps. And I was like, why aren't
Hmm.
they getting better? Or why are these coming back after like the recommended treatment? And I would go to like other urologist colleagues, other ND colleagues, other people within the Live UTI free community, and was asking. And then I met Ruth Kriz,
Hmm.
who's incredible. And then I reached out to her, and she has very graciously been mentoring me for the past year because once I met her and started implementing more biofilm work,
Hmm.
everything went way more smoothly. All my patients got better way faster.
Hmm.
And I was like, okay, I feel like this is it. So that's the long, windy road of how I got here.
Yeah, it's really great to hear about it. A couple of things you said really resonated with me, that magical moment where you just don't think about your symptoms anymore. A lot of people talk about the only time
Yeah.
they realize they're better is when they realize they haven't thought about their symptoms. You don't necessarily notice it happening, but then you reach a point where you notice it's gone. And that's always a
Mhm.
really nice moment for people. And I also think it's really important to interact with other clinicians and researchers in this whole space because everybody has a different piece of knowledge. And if we're all talking together, then patients will be helped faster. And it's one of the reasons that we made this channel so that we can
Yeah.
keep all these conversations going and share that expertise. But like I said, we got a lot of questions about biofilms. The patient community is quite educated about this topic, but they always have questions. And the first
Mm.
one is sort of a background question, which is what is the evidence that biofilms exist in the bladder?
Yeah. So there is good evidence that we have biofilm bacterial communities in the bladder. A lot of the research started out on devices like biofilms on pacemakers
Hmm.
ages ago. But now we know that, especially in recurrent UTI and chronic infection contexts, there is like a strong evidence base for these intracellular bacterial communities that tend to even go into like the tissue or the lining.
Hmm.
Um, Also, like catheter or device related biofilms are in the bladder as well. And it's not like they're easily visible on the surface, and we can't necessarily take a biopsy and see them. Or I've had lots of patients go for a cystoscopy and they're not going to see like a giant biofilm because
Hmm.
sometimes it's either only on one side, like you can have one on the right, one on the left, but it's not superior. You can have it just on the inside or inside the lining of the tissue, and then it's not as visible. Biofilms also have a lot of crazy mechanisms, like
Hmm.
something called quorum sensing, where they can communicate with one another despite, say, one being on the right, one being on the left. And they can tell each other through like a walkie-talkie sort of, these like cellular signals that, oh, I just saw a mox clav. This is how it works.
Yeah.
Now you can become resistant to it. It's kind of wacky. Um, and so there's animal and cell studies that have shown pathogens like E. coli can invade the epithelial cells and then form these communities that are like biofilms, and it helps prevent any sort of immune clearance. So the immune cells can't see it and can't help you there. And then it also will evade the antibiotics. And then we have human urine studies, so like samples of urine from humans that have reported biofilm-like bacterial aggregates, like chunks,
Hmm.
and intracellular communities in those samples that were taken from infected patients. So we do have support that there are biofilms in the bladder in humans. I think there's also a question later on, but I'll just mention we can get biofilms on kidney stones
Hmm.
and in the kidneys, but it less so seeds to the bladder. But I think we'll chat about that later. I think the main uncertainty is not whether bacteria can make biofilms in the urinary tract, but how often, like a classic mature biofilm is present
Hmm.
and how best to detect it because we don't really have good detection methods at this point. And they can be kind of like patchy, as I mentioned. So a negative biopsy or a negative urine culture doesn't rule out a
Hmm.
biofilm related infection.
That makes sense. And we have covered that topic in some of our other videos as well, how hard it is. There's no test that can tell you for sure that there's a biofilm present. But that kind of raises another question because biofilms exist throughout the body and in nature naturally. Microbes tend to make biofilms just as part of their activity. So how do we know if a biofilm in the bladder is problematic or if it's made up of good organisms?
Yeah, I really like this question because I hadn't thought about it that much. I just treat the bad ones and
Hmm.
usually things go smoothly. But I was like, huh. So I looked into it and thought, okay, it sort of depends on the context and how the body's responding. So symptoms are what like paint the picture and tell us
Hmm.
what's going wrong. And so when a biofilm is healthy and part of that commensal community, and it's going to support a host's function
Hmm.
rather than evade it or cause problems. So some biofilms will help maintain the gastrointestinal tract lining and create a harmonious relationship, or they might help a probiotic evade the gastric juices and go to the small intestine where they're actually beneficial.
Hmm.
But when they're problematic, it's usually when they're associated with symptoms of damage like recurrent infection, chronic inflammation, antibiotic resistance, or colonization of devices. Those are going to be your
Hmm.
pathogenic biofilms. So if they're associated with pain, dysuria, or pain with urinating, urgency, fever, discharge, recurrent infection, then it's like a pathogenic one. So sometimes those clues can be diagnostic and tell me, okay, it's likely there. I should
Hmm.
try treating it. And then protecting the beneficial ones while killing the pathogenic ones is usually just like timing and probiotics,
Hmm.
like trying to replenish maybe what's lost while killing it all off. Luckily, the treatments for biofilm disruption are fairly benign, so they don't come
Okay.
with a ton of like risk or side effects like antibiotics do, where there's like resistance, risk of
Hmm.
C. diff. Those I try and time a little more gently, do no harm. Yeah.
Right, makes sense. Are there
Yeah.
certain organisms that are more likely to film biofilms in the bladder than others, and are some harder to treat than others?
Yeah. So Ruth Kriz actually has this amazing table of every
Hmm.
bacteria, um, the pH it exists at, what biofilm it makes, whether it makes histamine. It's great. I follow it with every patient.
Hmm.
And so almost all the bacteria that can cause a UTI create biofilm. And the tricky thing is biofilm can start being made after like 2 hours. Usually not that fast, but like 2 to 8 hours, and you can have some formation, but that can be killed with an antibiotic on its own. So it
Hmm.
happens quick. And then there's definitely some that are more stubborn than others. So ones that I tend to have trouble with or need to treat longer are Enterococcus faecalis. That's pretty common. That one's
Hmm.
really stubborn. It just takes a little more treatment. Serratia is a really annoying one because I think it makes both biofilms, ammonia, histamine, so it takes a lot of treatment. Serratia is also the example I give for people because it's like the visible biofilm you can see on
Hmm.
your bathtub or your toilets with that
Hmm.
pink slimy mildew.
Nice.
That's serratia.
Hmm.
Um, and then Klebsiella is also a toughie because it makes both types of biofilms and ammonia. So it just takes a lot of treatment and timing.
That's complicated because, as you mentioned, there's no test to diagnose a biofilm, and biofilms are often not in samples unless parts of it break off, like you said, into a sample. So, how do you know what's there? What type of testing do you use so that you can make these complicated decisions?
Yeah, so I use Microgen, which will tell me which bacteria, the amount, what antibiotics are sensitive,
Hmm.
and if it's like a polymicrobial infection, so more than one pathogen. So Microgen can detect bacteria that's inside a biofilm to some degree. But I also will always give my patients biofilm disruptors for about a week before they take their Microgen
Hmm.
sample so that we break it open to make sure I'm catching everything that's in there if it is polymicrobial. So that's sort of how I get around not having a good test for biofilm.
Hmm.
And then whatever bacteria comes out and is in their testing, we'll treat the associated biofilm because there's very minimal risk and very large benefit.
Hmm.
Mhm.
Yeah, that makes sense too. One of the questions that comes up, which you've sort of touched on a little bit, but can biofilms in the bladder cause symptoms even if the urine test comes back negative, if you're using a test like Microgen?
Oh, test like Microgen, that's a good question. I was going to say standard urine cultures, yes, 100%. You can have like symptoms with that coming negative. With
Hmm.
Microgen, maybe if it's like a very robust biofilm, but I
Hmm.
haven't seen like Microgen testing come back negative ever, I don't think, if
Okay.
somebody has symptoms.
Conversely, if the symptoms subside in between UTI episodes, is it possible that pathogens are still there in a biofilm even if you don't have symptoms at times?
Yes, so it's possible that there's still biofilm inside. So
Hmm.
if you said if your symptoms subside in
Hmm.
between, um, so symptoms might subside initially, like if you've had a course of antibiotics for 7 days, 10 days, 14 days, and if you feel great on antibiotics, and then the day after you like start to feel symptoms again, it's
Hmm.
usually a biofilm issue.
Hmm.
If the symptoms go away in between, it's usually that the bacteria has gone back into a biofilm formation. So you don't have any planktonic bacteria like free floating in the urine
Hmm.
anymore that could wreak havoc on the lining and cause those symptoms or urethral symptoms. So it can go back and be calm for a while, but with those people I usually see, they might have relief for a week and then symptoms like very slowly,
Hmm.
gradually start to come back or worsen. If you don't get any symptoms return at all, that's a great sign. So that usually means that you've treated it and there isn't much left or any biofilm. The beauty of getting the bacteria out of the biofilm and into the bladder where it's free floating is also water is going to help you. Like you're going to pee out a lot of that bacteria. So sometimes it can just resolve afterwards with some like extra supports.
How long do you think you would need to be symptom free to then feel like you have cleared the problem?
I'd say 2 weeks.
Okay.
Like if it's not coming back, you're not having dysuria frequency burning for like a solid 14 days, you're likely in the clear. And I
Okay.
always continue probiotics for 2 or 3 months afterwards, after any course of
Hmm.
antibiotics, to help outcompete any pathogenic bacteria. Sometimes that can do the trick too. If
Hmm.
there's just like a minuscule amount of bacteria left over, you that doesn't require an antibiotic, you can use some other supportive things to just help stave it off.
Okay. You mentioned this briefly at the beginning about kidney infection. So people often ask, do biofilms form in the kidney, and could this be feeding bacteria into the bladder, and that's why their infections keep coming back?
Yeah, that one's also an interesting question. So biofilms do exist in the kidney. They can exist on kidney stones or in like the renal papillae, or if you've had pyelonephritis or a kidney
Hmm.
infection that like keeps recurring, they can be there. Usually there's like a disruption to the kidney microbiome. So the kidney actually also has its own little microbiome that's mostly Lactobacillus crispatus and
Hmm.
bifidobacterium, same as the bladder. Um, but the caveat is that the kidney biofilms don't usually seed to the bladder. Like it doesn't go from up to down. Usually it goes down to up. So if there's an infection in the bladder, it can seed up the ureter to the kidney more often. Not to say that it maybe couldn't happen the other way around. Um, but yes, we do have some animal studies that show kidney biofilms in humans. I mean, it's anecdotal, or I'm just imagining from the studies. We
Hmm.
don't have human sample, like human kidney biopsies, because that would be too invasive and
Hmm.
probably would not pass like an ethical board
Yeah.
to take kidney samples from a human. But yes, they can exist. And sometimes there is like this reservoir problem, we call it,
Hmm.
where like if there is a certain bacteria in the kidney or say the vagina that has a reservoir and then shifts over to the urethra or into the bladder. There's somewhere where it's like pulling from.
That it also is kind of logical to think that the kidneys have a microbiome of their own, as does the
Yeah,
bladder. But it feels
yeah,
illogical that mostly infection would ascend rather than descend given the direction of the flow of urine. Do you have any
yeah.
theories about why that might be?
I know it does sound illogical. I think like our bodies are pretty smart and the kidneys are so crucial and protected and the ureter is so long.
Hmm.
I feel like there's these protective mechanisms that help prevent an infection from going to the kidney. Like we try and keep it in the bladder or the urethra as much as we can, because if our kidney gets harmed, that can be very dangerous. Um, going like it could happen with a kidney stone or some sort of
Hmm.
recurrent kidney infection that it goes to the bladder because it's all connected. It's just
Hmm.
less often. Not to say it, but yeah, it could.
There are a few people in our community who report this type of experience where they do have recurrent kidney infection and then
Mhm.
occasionally a bladder infection. So they perceive this to be happening, but it is something that seems less common. And therefore, there's less
Yeah,
research into it, which makes it complicated.
yeah. But I Ruth is always laughing with me because she's like, you have the craziest cases. She's like, I've never seen this before. And she's been doing this for 50 years.
Hmm.
So I always see the weird, wacky, complex ones. So it definitely could happen.
Hmm.
There's, yeah, physiological reason. And I mean, it's all one urinary
Yeah.
tract. It's connected. So for sure, it could be just, yeah, less literature.
Yeah, and I think that's an important point as well because patients often feel like they're the only person that has this complicated case or this particular constellation of symptoms or occurrences. But I think there's always other people, and it's important to let patients know they aren't alone. And there are clinicians looking at
Yeah.
complex cases and trying to figure them out.
Hmm.
What do you think about biofilms in relation to interstitial cystitis or bladder pain syndrome?
Yeah, this is a good question too. So I think like interstitial cystitis or painful bladder syndrome is a diagnosis that you can have, but it's a diagnosis of exclusion. So it's
Hmm.
not like the best one that we want. We want to find like a reason. Also,
Hmm.
patients usually want a reason why this happened to them.
Yeah.
So I think biofilms are one possible contributor, and it's the contributor I see the most in my practice because patients usually come for chronic UTIs.
Hmm.
And so if they have interstitial cystitis and they come into my office already with that label on, then I usually ask them, have they had a UTI before? And does it coincide? Like, did you get a UTI and then the interstitial
Hmm.
cystitis came shortly after, or even years down the road? And if the answer is yes, then we always go down like the microgen rabbit hole and
Hmm.
see if this is a biofilm issue and an embedded infection. If they didn't have a UTI ever, because I have had some patients like that where they're like, I've never had one, but I have these bladder symptoms.
Hmm.
Then I kind of look at the other constellation of what could have caused this, which can include just like bladder pain processing, so like a neurogenic bladder and
Hmm.
MS, or like a barrier dysfunction, like genitourinary syndrome of menopause, pelvic floor dysfunction. Is it like a musculo-ligament
Hmm.
issue, or um, microbiome related, food related, mold related? Mold can agitate the bladder. So I kind of look at the different spokes and see what might be going on. That's how I approach it.
Yeah, I remember reading a paper once that showed that 79% of people who had been diagnosed with IC or PBS had previously had recurrent UTI. So it's quite a
Mhm.
substantial amount of people where there does seem to be that connection. So is that how you kind of approach it, that that's the most likely diagnosis? And then if that's not the case, it could be something else?
100%. That's usually the first question in the visit is like, have
Hmm.
you had a UTI? When does it coincide? And then I'd say like 90% of the time, it's not IC, it was a chronic infection.
Yeah, I'm sure that's very validating for patients who've been trying to find answers to find something that they can try to treat rather than management
Yeah,
without any hope for treating the problem.
yeah, exactly.
So let's talk about some of the treatment approaches. Why do standard antibiotics struggle to penetrate biofilms? And are there any data to support certain antibiotics over others in their ability to penetrate biofilms?
Yeah, I love this question. So, biofilms are this crazy goo, and they have so many mechanisms. So, they are both a chemical and a physical barrier. They're like a giant scaffolding, like holding the bacteria in like a bowl of jello, um, to paint a picture. So, will slow the drug entry. Like the antibiotic just can't swim through that. They can inactivate the drugs chemically. They create a low oxygen environment, low nutrient environment, and the biofilm can also contain like slow growing or dormant cells.
Hmm.
They can also contain cell wall deficient bacteria, which an antibiotic will never treat. Um, that's another story. And
Hmm.
then biofilms have like polysaccharides, DNA, and proteins that create this matrix, and then the drugs just cannot reach the deepest layers at meaningful concentrations, really. They kind of
Hmm.
just fizzle out. So the inner biofilm can be really hard to treat, but the outer layers sometimes you can touch with an antibiotic, and it might just take time. I
Hmm.
think that's sort of the theory with like some practitioners who use really long-term antibiotics, like the 6 months or 1 year of antibiotics,
Hmm.
is that some antibiotics do have um, like biofilm disrupting properties, but to like a lesser degree. It just
Hmm.
takes so much time. So I did try that in like my initial few cases
Hmm.
because it was recommended by other colleagues. And then I just found it didn't work. And it honestly increased the risk of C. diff past my comfort zone.
Hmm.
And so that's why I was like, this isn't for me. I'm gonna go talk to Ruth and try and figure this out in like a safer way. Um, and I did, and like it's been great. But some of the antibiotics that have better uh, biofilm penetration are the macrolides, which is like your erythromycin, clarithromycin type drugs, the tetracyclines like doxycycline. That's a common one used for Lyme, which also creates a lot of biofilm. The quinolones, which are like your ciprofloxacin, levofloxacin.
Hmm.
Those families tend to be better. Those families are also little harsher. They come with more side effects, like Cipro can cause tendon issues. And then the ones that have like less penetration would be your beta lactams, which is like your amoxicillin, penicillin family, your
Hmm.
cephalosporins, which is like Cefixime in Canada for me. I know in the US, I think it's called Cefnadire.
Hmm.
I'm not good with all the
I've
names in the
heard of that one,
US.
yeah.
Yeah. And then the glycopeptides like vancomycin is not great at biofilms.
Hmm.
It's not one we typically use for UTIs. But when you are breaking open a biofilm with other agents, like enzymes, for example, you're not really worried about like antibiotics having to do that job.
You mentioned vancomycin as a glycopeptide, I think you said. Is gentamicin in that same category?
I think gentamicin is a different class.
Okay.
Vancomycin is like a glycopeptide, and it's the non-synthetic one. And then
Hmm.
the synthetic ones, you might be right, I think are gentamicin.
So I'm just thinking that a lot of the research into bladder installations is with gentamicin, and sometimes
Yes.
vancomycin is used. But if they have very low biofilm penetrating properties, then is it really helping as much as it could, even though you're delivering it straight to the site?
Yeah. I mean, let's chat about installations. And I'll preface saying, like, I don't do installations in my practice because it's out of scope for me.
Hmm.
We can do catheters, but we don't have access to like antibiotic solutions, just orally
Hmm.
as NDs in BC. And so I just know from my patients who get installations, and usually you're right, there is this like cocktail, I guess, of usually heparin, bicarb, like sodium
Hmm.
bicarbonate, sometimes hyaluronic acid, some type of antibiotic. Like I remember one patient was getting a mox clav in her installation, but
Okay.
I've seen gentamicin as well.
Hmm.
If you have a urologist that's willing to like base it off the sensitivity that you've done previously or like a
Hmm.
microgen, awesome. I find that works really well. Um, and then I haven't seen this yet, but in my research, you can add biofilm disruptors like EDTA
Hmm.
or DMSO to these installations to break down the biofilm and then allow things like gentamicin to be more effective.
I have heard Ruth Kriz talk about EDTA in particular in installations, and she also has worked with other clinicians who have that access. I did want to clarify that even naturopathic doctors in a lot of regions can't prescribe oral antibiotics either. But in
Yes,
Canada, is that broadly the case or just in BC?
only in BC. So we have prescriptive rights, but no other province yet, I don't think has
Okay.
them. I have my fingers crossed though. But yeah, I'm very fortunate that I get to use them.
It's helpful to have a wider toolkit to be able to use antibiotics in conjunction with other things. There's more questions about biofilm disruptors, but we have another question about treatment options
Mhm.
first and penetrating biofilms. So the question is whether bacteriophage therapy is more likely to penetrate biofilms than antibiotics.
Yeah, 100%. I've only had a couple patients do the phage therapy because I
Hmm.
think it's only accessible in England. Unfortunately, it's not available in Canada yet. So
Hmm.
the only way you can get it here is through like Health Canada clinical trials. I can't prescribe it
Yeah.
yet.
Yeah.
Hopefully one
Yeah.
day. So phages have this like built-in advantage and they're a living organism. They're like a viral machinery that's going to attack the specific bacteria that's programmed to, like E. coli or Proteus. And so it will definitely degrade the biofilms as well because it has these matrix degrading enzymes that it can produce called depolyamerases, which helps them work through the biofilm structure and then kill the bacteria while leaving the healthy bacteria like lactobacilli completely alone because it's
Hmm.
only programmed for one. So it is definitely more useful than antibiotics, I think. If there's good like trials that and research that come out of it, I think it could be amazing. Um, yeah.
There are quite a few research trials happening in different places in the world, but like you said, it's hard to access unless you're part of a trial or if you go through a compassionate use program, which is also very difficult and takes time. And sometimes infections change over time, which also complicates things. If you're waiting 6 months, things might have changed.
Yeah, that's the one thing I see with the phage therapy is it might start out like the two patients I've had do it in England might start out as E. coli or they take the phage therapy for E. coli, but then if it's a polymicrobial infection, we're still left treating
Mhm.
something else. So there's yeah, definitely caveats to it, but it does seem like a very interesting therapy. Like I'm curious to see where it goes in the coming years because it does kind of take away the need for like, using probiotics at the same time or
Hmm.
um, biofilm disruptors too. It's sort of like a one size fits all if you only have one bacteria.
That's part of the issue, I think, too. And because they usually develop the phage therapy for the particular organisms found, you can't just over-the-counter sell phage therapy that will work for everybody. And that's
Yeah.
part of the difficulty of bringing it to market in the way that would make it accessible to patients. But there is a lot of patient interest in that type of approach. And it's partly because of antimicrobial resistance fears and just the side
Hmm.
effects of antibiotics. So we're also interested to see where that research goes. Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.